Good afternoon, everyone. Welcome to this European Federation of Addiction Societies symposium. It will be co-chaired by me. I'm Colin Drummond from King's College London, and I'm also the president of the European Federation. And my co-chair is Professor Karen Ersch from University of Cambridge, who is also the editor of European Addiction Research, which is the official journal of the European Federation. And she will be introducing our special guest lecturer shortly. But first of all, it's my pleasure to introduce Professor Jürgen Rehm, who probably most of you will know as a highly distinguished and highly productive public health researcher who's based in the University of Toronto at CAMH. He's also chair in addiction policy at the Dalai Lama School of Public Health in Toronto University. And he's going to talk to us today about the increase of alcohol attributable mortality in the EU during COVID-19. Thank you.
Thanks for the nice words. I would like to see the audience, but I can't because the lights are blinding, but okay, we'll manage. What I'm trying to do today is I walk you through some of the recent data, and I'm also trying to combine some of the public health aspects with clinical aspects. So let's start. Basically, when COVID came, and that was in March 2020, we were asked to sit together and say, what will be the consequences of COVID? And that was obviously, none of us knew that this is going to be for 2 years, and this had all those severe consequences. But at the time, what we said is we will overall look into what it means for alcohol and the mechanisms how alcohol is consumed and why it is consumed, and the consequences for the population. So basically, two mechanisms were identified, partly because of a very small literature research on natural disasters and other pandemics. And what was predicted is that based on this mechanism, alcohol is a maladaptive coping strategy to manage the psychological distress due to pandemic, and that we know will cause population stress. But then there's also a second mechanism. During all pandemics, infectious diseases, there will be different measures like distancing, like actually bringing down whole cities, bringing down whole countries, not opening restaurants, etc., etc., etc. And that's clearly an availability mechanism. And then there's also an affordability mechanism, because during pandemics, a lot of people will lose their jobs worldwide, and they don't have enough money to buy alcohol. So those two mechanisms would go down. And basically, what has been predicted then is that the mechanism one would be a mechanism already for vulnerable people, people who were drinking a lot beforehand, people who have other mental health problems, and the majority would be in the other mechanism, meaning, okay, there's a lockdown, I'm not going to break a lockdown just to get my alcohol, I can live without my beer today. That's what most people we predicted would do. What does that mean, however, for the population? In the population, basically, we almost religiously follow from kettle brewing to Ole Jürgens Coke to the modern stuff, that what you need to do is you need to shift the population. You need to shift the population to the left. If the country drinks less, if the mean drinking is less, there will also be less alcohol use disorders. So that is the classic public health theory, that populations are going up and down in concert, and that means that decreases or increases would affect all groups. They may not affect all groups in the same proportion. That has been shown that the most heavy drinkers reduce proportionally less than the lighter drinkers, but otherwise this is the main theory. And as I said, we predicted that this theory would not hold true during COVID. So what was exactly predicted? Based on what I just told you, if you look into the population, and I've just made 5 20%ers of the population, the top drinking level would go up. They're the most vulnerable, they're the most heavy drinkers, they would go up. The second would stay, and the whole rest of the population would go down. Obviously, we had no clue if it's 20% or 10%. We are not that exact in our science. We just knew that the heaviest would increase, the others would go down. And that is what was predicted. Now, what happened? Well, there are some reviews for the EU, and this paper is mainly about the EU, but I can assure you that worldwide, of the 8 reviews, all found the same pattern. And the pattern are that the heaviest drinkers increased despite, in the world, a big decrease of consumption. Alone in the first year, alone from 2020 to in 2020 compared to 2019, we had about almost 10% decrease. During COVID, overall, the decrease was about 15% worldwide. So it's very clear that overall consumption decreased. If WHO, if the UN will ever reach their drinking goals, it is not because of any policy, it's just because of COVID and because the Communist Party in China had the anti-corruption campaign. These are the only big movers drinking down. The whole rest is pretty stable and pretty bad. So, what happened in the EU? Alone in this first year, APC, means alcohol per capita consumption, went down by 0.7 liters, which is quite a lot. And in the individual studies, Carolyn, who is here, she made a review, and she found in her key findings that among people with pre-existing high drinking levels, alcohol disorders, use disorders, high-level drinking papers appear to have solidified or intensified. That is as predicted. Then there's a number of single studies, there's a number of EU countries, and basically it is very clear in none of those studies, to my knowledge, the population went down in concert. So Ole Jürgens Koch's theory did not apply. So what are the consequences now for clinicians and for clinical sciences and for policymakers? Well, basically, I'm giving you some of the other reviews during COVID-19, and basically what you see is that the biggest systematic reviews actually all had the same result. And here I give you a world map to show you that Europe is not that different. The majority of the countries are in blue or light blue, and there are a few countries who actually increase their drinking, albeit to usually a smaller proportion. Most prominent, the US. What did the US do? They did everything to declare alcohol an essential good. What is an essential good? Basically, we make sure that the population gets drinking. So we increase availability by, for example, allowing delivery systems, which were illegal in most states, or in many states, not most states. Same with other countries. Online delivery, the Ubers, and they were actually coming around, and they were trying to get the people alcohol in those situations when there are lockdowns, etc., etc. They got special permits. There was a big thing in France that they say, oh, we have to make sure that people with alcohol use disorders do not go into withdrawal. There were lots of little law changes to make sure that the drop was not as bad as it looked like in the beginning. And actually, you could see all of that, of course, also in the reviews of the alcohol industry. They were jubileeing in every single of their pamphlets. Oh, we've made this big success, and this will change forever, etc. So if anybody wants, you see that those who increased APC more than 0.3 are less than 15 countries, okay? So, now, what are the indicators for healthcare? Well, the indicators for healthcare didn't help us, because what happened in Europe is that whole hospitals were entirely dedicated to COVID. So very clearly, you had quite a lot of different patterns, and you could not simply compare healthcare utilization data, let's say for alcohol use disorders, because obviously treatment for alcohol use disorders went down in all countries of Europe because the doctors had other things to do, some hospitals were closed, etc., etc. Plus, the patients were fearful. They said, okay, I would go to the hospital now, but actually I may die of COVID, and I'd rather continue with alcohol and go to the hospital after this crisis. So we looked into a good indicator, and the best indicator in our view was 100% AUD mortality. Why? 100% AUD mortality is basically a set of diseases which wouldn't exist without alcohol. So we could have done some other diseases like general liver disease, etc., but there we don't know how COVID would impact, so we went to the 100% alcohol use disorders, and the main diagnosis there is, of course, what used to be called alcoholic liver cirrhosis, nowadays alcohol-related liver cirrhosis, alcohol poisoning, alcoholic cardiomyopathy, the different pancreatitis, all of those diagnoses. These diagnoses are not negligible, but they're, of course, compared to something like cardiovascular diseases or cancer, not the major cause of death. Okay, so what happened there? Basically, the mean age-standardized mortality rates of 100% alcohol-attributable diseases in Europe, this is an average of countries. For all the countries where we had data, which were 19, believe it or not, the countries have, at this point, we have October 2024, more than 1/3 of the European countries have not sent their death data yet to WHO. And that means, because everything, the Global Burden of Disease study, everybody uses the WHO data first, and then they do all their calculations. And that means we are really in a mess. The countries are usually late in delivering data, but this is a mess, and you see it that we had only 19 European countries. In those countries, there was an 18% increase of alcohol-attributable mortality. 18% is pretty high. But we had also, and that's part, we did that because we have a project in the Baltic countries. So we are quite often in the Baltic countries. And we, NIAAA, the National Institutes from the US, are paying for this. And so we had done specific hypotheses for the Baltic countries. And we, because of their past, because of their drinking patterns, did a prediction that they would increase more. And we measured that. Actually, the increase in the Baltic countries, the 3 Baltic countries together over 2 years, was almost 50% increase in alcohol-attributable deaths. That is a lot. Alcohol-related liver cirrhosis is not that rare in the Baltic countries. So this is quite a lot. And the rest of Europe then increased only by 8. But it was still an increase. And what is also interesting is we have an increase in 100% alcohol-attributable deaths and a decrease in overall consumption in those countries. That usually doesn't happen. We did the correlation between consumption and 100% alcohol-attributable deaths for the years 2010 to 2019, the non-COVID years. Of course, a positive correlation. The more people drink, the more you have 100% alcohol-attributable deaths. Very normal. And then in those 2 years, a negative correlation of 0.4. So basically, what happened is really that only the top 10 or the top 15% increased their drinking, but so radically that the death rate increased quite substantially. So, this is the graph. The red line is 2019. And here you see that the European countries, this is the 8% increase. The Baltic countries are actually quite different. Estonia was the one with over, Latvia actually within 2 years had over 50% increase. Estonia had almost 50%, and Lithuania had closer to 30%. Lithuania did a taxation increase during COVID, and that's probably part of why people, because in Estonia we have data, they had three or four taxation increases since 2000. In all of them, the alcoholic liver cirrhosis rate went down. So that is pretty clear, and that was just a reiteration of that. So basically, this is the result. But now, what does it mean? We have 3 reasons why this polarization is. The prediction which we did in the very beginning, maladaptive coping strategies to manage psychological distress and mental disorders with alcohol. Classic, self-medication, etc. Secondly, a decrease of treatment of people with alcohol use disorders during the COVID-19 pandemic. As I said, there were less treatments in all countries. We checked the data, we don't quantify them, but there were less treatments in all countries just because people didn't go to the hospital for treatment of fear, and some hospitals did not accept patients for some time. But also, there was a systematic discrimination of people with alcohol use disorder in the general hospitals. I'll give you some data from France. And then a third is basically new social marketing strategies. I mean, I don't have a cell phone, but you probably have one. And if you type in alcohol, and too often you get those ads from social media. I see some nods. Yes, that's what happens. And the more you drink and the more you have indications that you drink, the nicer they target you. So part of that could be that with the new marketing strategies, we actually have more people being targeted. Okay, so let me go into the medical reasons. I've talked about that, and this is basically just a repetition. Then, the COVID-19. This is of all COVID patients which were going to the hospital in France. This is the whole database. We have 11 years of data, and we controlled for everything. Sociodemic, multiple somatic conditions, pandemic periods, everything was controlled for. And overall, there were about, between 400 and 500,000 inpatients with symptomatic COVID-19. And we checked what happened to those who had alcohol use disorders or mental health problems. Unfortunately, France did the following. Whenever they did a triage, in the high times, there were high times when the hospitals had to refuse patients. When they did this triage, the guideline said you should triage based on age and on terminal illness. These were the two triage reasons. What they did, they triaged on alcohol use disorders and mental health. Meaning, a lot of those people with alcohol and mental health disorders, even though their somatic condition and their life condition was overall so they should receive treatment, did not get treatment. We did not have a systematic why, but we did some qualitative interviews, and doctors and nurses said, look, they're so crazy, those patients. We can't deal with them. We have to deal with COVID. We can't accept them. So basically, part of the higher death rate is due because people were systematically stigmatized and refused treatment without a legal and ethical reason. And that went to Parliament, by the way, this study. So, and in those, that means that alcohol dependents in those high times had 15% higher chance to die because they were overproportionally denied life-saving therapy like oxygen, etc. And the same was true for mental disorders in total, and very clearly there was a big difference between mental disorders and without mental disorders. So this is something which was just one of the reactions of society. And the modern social media marketing, there are some explorations. Nick Carra has done some of those studies. Basically what he does is he brings together a lot of those social media users, gets their consent, and then they send him whenever they are sent any link from social media which would link to alcohol. And that he explores. So he has some 1,000 people, and he explores how those algorithms, this is all algorithmic, how these algorithms work. And he basically said that it's very clear that one of the reasons could be that heavier drinkers get different links and get different triggers to continue their heavy drinking. So, what do we do? Well, first of all, states, governments should actually predict those consequences. This is not the first pandemic. We had SARS in Canada. Wow, government said, we will learn, we will learn. Nothing. There was no learning effect. COVID, we will learn. We told them, no, we do not prepare for the next pandemic. We will prevent the next pandemic. What nonsense. How can Canada prevent the next pandemic? As the only country? Highly unlikely. So basically, part of the increases in heavy episodic drinking is because governments failed to act. Not enough things they did. Then, what would be the scenarios? Basically, we should think that the healthcare system must be strengthened over and above COVID, because otherwise, long-term, there will be more costs. And that is something we have to realize, and also the politics should actually not encourage drinking during COVID and say, oh, doesn't matter, those 2 years we can let them drink and then we do our alcohol policy again. No, that's not the right strategy. It actually costs lives. And for the marketing, if that is true, and it has to be shown empirically, what I just said, cannot be one study. The only thing would be a ban on social marketing, and that functions actually. Good. So, conclusions, implications, because I want to leave some of the time for questions. As predicted, we had clear signs for polarization of drinking in EU countries during the COVID-19 pandemic. These changes led to an increase in 100% alcohol attributable mortality. When we presented that to the government, to the doctors, oh, then probably a coding change. We checked the codings. We actually did 2 case studies. None of that. It was really the polarization. Healthcare systems also need to prepare. If we know beforehand that during and after a pandemic we will have an increase, well, why not do something? Why not put more money into mental care for these years to get back to normal? That is cost effective. And then a lot was predicted before, and those deaths could have been partly prevented if governments would have implemented proper alcohol control measures instead of trying to make sure that alcohol is maximally available. And healthcare systems overall should be much better prepared for foreseeable trends, such increases as heavy drinking during pandemics. And I could do the same talk for depression, for other diseases, so I'm not gonna bore you longer. I will stop here, and I'm open for questions. Thank you.
Thanks very much, Jorgen. It's quite difficult to see if there's any questions. There are microphones down the front if people want to bring themselves down there. Yep. Go ahead.
Thank you, Jürgen. That was a very nice talk. You did the mortality data. Have you done also morbidity data, alcohol-related morbidity?
Basically, the alcohol-related morbidity would be hospitalization data, and at this point, no country has delivered their alcohol-related morbidity. What is happening is that there are currently a lot of models trying to model the morbidity without COVID. So we have a net effect of what would happen without COVID. Is it an increase or decrease? And the modelers are not at all in consensus on how to do that. And at this point, I would not trust those data, so we did not do that.
Yes, thanks for your talk, Jürgen. Were there any specific differences or in age groups or by gender that differed between, pre and during that COVID time? What happened to young men, or was it the usual people that were dying that kept dying? Basically,
the dying was more extreme for men than for women, meaning the gender gap increased and didn't decrease. There's also vulnerable people for other reasons than drinking or mental health who increased their 100% alcohol attributable. For example, in Estonia, where we had the 50% increase, 40% of the population are Russian. And while in the death certificate, we do not have, of course, the country of origin. It's not part of the death certificate, but we have in Estonia parts of the country where 70 to 80% are Russian and where 10% are Russian. And the main bulk of the increase in 100% alcohol attributable mortality was in those predominantly Russian communities, meaning in Estonia, for example, being a Russian together with Ukraine, together with an increase in other problems, created this special vulnerable situation which led to an increase in drinking.
Thanks for this work. The explanation of the increase in consumption in the United States makes perfect sense. I was wondering if you noted any trends or factors common to the other 15 or so countries that also saw increases in consumption. I noticed on the map there was also Chile and Norway. So would you also attribute that to industry and a lack of appropriate controls, or did you notice anything else in countries that experienced an increase?
I mean, if you look into those countries, most of them, almost all of them are high-income countries. Russia by now is also a high-income country. That was the only one not at the time. But Chile is a high-income country. Australia is a high-income country. US is a high-income country. So that is one of the trends that only countries who were pretty wealthy came up with those ideas. We have to help the industry, and actually the industry pays their taxes there, if they pay taxes, but they pay more taxes there than they pay in the low and middle income countries. And so that would be one ex post explanation, but somebody has to do a research why people changed their policy and they changed policies which were there for 50 years. And suddenly it was no problem to change them. Before, it was 3-4 times they tried and it was not changed. But that would be a first explanation.
Great presentation, as always. I've got a practical rather than a scientific question. Now, government's preparedness for a future pandemic sounds good, But there are some practical issues. And I remember back in the UK in 2020, where there were pop-up hospitals, for thousands and thousands of patients with COVID, as well as mental health disorders. Problem is, no staff available. So how can a country increase its responsiveness to these sudden onset pandemics? I'm not expecting just a straightforward answer, but it is an issue. How does a country, any country, get ready for such a pandemic and respond quickly?
There's always limits on how much you can prepare. But then there is some really easy things. When SARS was in Canada, and I'm speaking about a country where I know a little bit. When SARS was in Canada, the last big thing, they stored several millions of masks.
Face masks. Yeah.
Face masks. Only, and then once they dug them up during COVID, they were all not usable again. So in Germany, there was a big scramble, several scandals, where corrupt politicians made a lot of money trying to organize masks because masks suddenly were out of. So those little things, if you have a stock and if you actually do something, would help. Second problem, once you do confine, we have a lot of homeless in Canada. The homeless had to be confined in one of those tents. The tents, homeless have in Canada about 60% have alcohol use disorders. They got nervous, so they did not know what to do. And very clearly, to avoid withdrawal, you had to give them alcohol. They did not have guidelines how much there are. So we had to call David Nutt to say, how much alcohol can we give? Those little things, guidance documents, how to behave, were completely lacking, and they can be prepared. And if people were on the ball, they could do it. Some cannot be prepared.
Okay, I'm afraid we're going to have to move on there because we've run out of time on this part of the session. But if there's time right at the end, I think we can come back to questions. Sorry about that. Thank you, and thank you for some great questions there. So we're moving on to the next part of the session, which is hosted by the European Federation of Addiction Societies, and as I said at the start, I'm currently the president. Just to say a few things about it, the society was founded in 2010 with the aim of promoting education and the attainment of the highest level of knowledge and understanding in the field of addiction in all European countries, insofar as such activities shall be wholly non-profit and charitable. And for the purpose of this organization, we're covering all addictive disorders, including behavioral addictions. It was founded in 2010. Carl Mann, who's with us today, he was the founding president. Currently, we have 38 national European addiction societies who are part of the organization across 26 countries. And in 2023, we introduced affiliate membership. I'm pleased to see so many of the EUFAS executive here with us today, who are, as you can see, spread across the whole of Europe. And every year we introduce, every 2 years now, we introduce a EUFAS European Addiction Research Award in collaboration with the journal European Addiction Research. And it's awarded to scientists who have made an outstanding contribution to the field of addiction during their lifetime. And we do a presentation at the annual symposium. You can see our previous laureates there. So I'm going to hand over to Karen now, Karen Ersch, to introduce this year's awardee.
Yes, thank you. Hello, everyone. Perhaps I can click onto the next. Oh, no. I have a slide, so that needs to be shown. Yeah. Oops. Well, hello, everyone. My name is Karen Ersch. I'm the editor-in-chief of European Addiction Research, an international scientific journal for innovative research that covers all aspects of addictions and related disorders. And as you've just heard, since 2016, European Addiction Research and the European Federation of Addiction Societies collaborate to present the European Addiction Research Award that is awarded to an outstanding scientist in addiction research. And this year's winner is Professor Andreas Heinz from the University Hospital Charité in Berlin, where he has a chair and is director of the Department of Psychiatry and Psychotherapy. And it's my pleasure to hand over this award to Professor Heinz, a distinguished German psychiatrist and neurologist who has made significant contributions to the field of addiction, mental health, and neuroscience. He studied not only medicine, but also philosophy and anthropology. And as you can imagine, his research interests are broad. So are his contributions to science, which include insights into influences of social, cultural, and genetic factors on brain development and mental health, including addiction. He also conducted seminal work on abnormal reward processing and alcohol use disorder, using various neuroimaging techniques, including magnetic resonance imaging and positron emission tomography. And he was one of the first who applied learning theory to understand addiction and used computational modeling approaches to reveal the processes underpinning addictive behavior. He's also now leading a large multi-center research program on exactly that topic, namely to understand the mechanistic processes underlying the development and the neuropathology of addiction, and to use this knowledge to develop more effective therapeutic interventions. And when I look at this title that he's going to give us today, I'm sure we are going to hear more about this, and we are all looking forward. So many congratulations on your award.
Okay, all right, thank you. All right, thank you very much for the nice introduction. It's my pleasure to give you an overview on our research and research from related groups on learning mechanisms in addictive disorders. I'll have a focus on alcohol use disorders. Maybe one word before we start, why focusing on learning mechanisms? Well, number one, of course, we know that alcohol and other drugs of abuse impact on systems that are very important in human learning. But it also has another side, because most of our interventions are somewhat related to cognitive behavior therapy and related to impacting on modifying behavior via learning mechanisms. And it's also probably a rather positive note, because whatever you can learn or you do learn while taking drugs, you can probably change when you get the adequate space, situation, time, and maybe help to really cope with maladaptive behavior. So this is a reason to focus on these learning mechanisms. And I'll go with you briefly through development and then maintenance of drug addiction. And we know that in the factors that predispose people, in this case for alcohol use disorders, there's rather a strong balance between environmental factors and genetic factors. So here I've circled for alcohol use disorders, but pretty much the same for drug use, illegal drug use disorders. There is a strong increase if you are adopted into a family that does not use alcohol, but you have parents, biological parents, who do use alcohol. This is this 1.46 increase on the right-hand side here in this table, but it's nearly the same increase in your odds ratio, about a 1.4 times increase if it's the other way around and you're just adopted into a family in which alcohol use disorders are occurring, while your parents, biological parents, do not have any problems. So it probably pays to focus on these modifiable environmental factors. And one of the strong factors predisposing people to drug use and also alcohol use is early childhood physical abuse. From some studies, we know that this increases the risk for alcohol dependence by about more than twofold, but also for frequent drinking. And what I show you here is an animal model that I encountered when I went to the States in the 90s. And this is rhesus monkeys that had to grow up without their mothers. This is a very traumatizing situation for the monkeys because they're usually held for 6 months on the belly and get a lot of safety from this procedure. And when they grow up alone, it is heartbreaking. They really very much look like what you may have heard reported from orphanages, that they hold on to each other, they show stereotype behavior, they're very anxious. And what was examined here was serotonergic neurotransmission, both by looking at the cerebrospinal fluid and by looking at transporters. The transporters are mainly located in the Raphe area here in the center. Oh, did the wrong thing here, sorry. Probably that should be the spot. So this is the Raphe area on MRI, and what we looked at was serotonin transporter availability. So when under stress, the serotonin turnover goes down, and it does go down long term. The transporters are not occupied with endogenous serotonin, and our radioligand can bind to them. It's pretty simple, and it's the same negative correlation up here is in monkeys and up down here is in humans, so that's probably the same mechanism. But interestingly, these monkeys that I show you here are already 5 years old. This is pretty old for rhesus monkey, and still you can see, although I have to admit I got the two extreme examples. This is one growing up without a mother, that's one growing up with a mother. There are still differences in their serotonergic neurotransmission. And how do they predispose to drinking? Well, quite obviously they're anxious, and when they consume alcohol, even as young monkeys, they tend to get a little more relaxed. And they also tend to be able to drink more before they're intoxicated. It's as if they are under hyperarousal and they need more sedative GABAergic neurotransmission, seems to interact with serotonin in order to get into a more relaxed state. And indeed, the more you have your serotonin alteration, this is here the transporter availability, the more they tended to drink. And as you know, the work of Mark Schuckett, it was pretty much like in the young persons Mark Schuckett examined. If you have less acute negative effects from drinking, you tend to drink more. So that's learning from lack of aversive effects of drinking. And I have to say that in my own personal acquaintances, I had a very tragic example. One of my best friends in school died at the age of 40 from alcohol use disorder. And when his brother called me, he said, when he was young, with 16, he could drink a bottle of whiskey without showing a single, any ataxia, nothing. And I always got a headache, and the brother who got a headache is now a neurosurgeon, and the brother who could drink a lot died. And that's also due to drinking culture in Germany. You feel that if you can drink a lot, you are trinkfest, you are strong against alcohol. But this is, of course, only true for short-term effects and not for long-term outcomes. And when I was in Mannheim working with Karl Mann, we also looked at a group of people, young people, 300 only, but followed up from birth to, at this point, the age of 15, and how much you can drink also had an effect on how much they do drink at the age of 15. I have to say all these factors we followed up together only explain 25, not even 25% of the variance. So there's a lot of individual variation we don't even capture. Although we had internalizing anxiety disorders, externalizing disorders, difficult friends, and so on, what you see also some genetic impact again of this serotonin transporter polymorphism. All effects are small. I always try to comfort parents who are not very good in supervising their children's drinking. That has an effect of about 3% on drinking, even less, 2%. But all these little brickstones or all these little effects sum up. So one reason to drink too much is you lack a negative effect of it immediately, and you don't learn that it's not good for you. Now, if social isolation plays a part, and this fits nicely into the previous talk, then there should be an impact on drinking, on alcohol use disorder. This is an old review we did of previous quarantine situations and said, yeah, there should be a problem, but we found the same that was just presented, maybe on heavy drinkers, which we didn't have, but we had mild to moderate alcohol use disorder patients according to DSM-5. And we have to say they were really very much like the social drinkers we encounter every day. We had some people recruited who said, I drink Friday 2 beers and I have a strong craving before and I have a loss of control because I wanted to drink only 1 beer and I had a bad consciousness afterwards and so on. They were a lot of the people we had in there, and what you see is every weekend they drink more. They drink much more on Christmas and New Year's Eve. These are the peaks here. And then came the hard lockdown, and we thought they would drink more. They actually drank less. Now, it may also have to do, this is January, it may have to do with good intentions for the new year, but anyway, the average drinking in our moderate consumers, I have to say, went down, as has been reported all over with the broad numbers in consumption. Okay, so one predisposing factor that could impact on how people learn to cope with alcohol or to deal with alcohol is you have not a lot of negative impact from your drinking. Now this just means you can drink more without immediately getting punished by headaches or by starting to slur your speech. Why do people keep up drinking? And in the new ICD-11, you have these double criteria. So I also have the double criteria now put together: harmful consequences, neglect of other interests. And one thing that, of course, comes to mind is brain atrophy associated with heavy drinking. This is a 40-year-old woman, and you see that it's not only the cerebellum, but also frontal cortex atrophy. And we know from work of Karl Mann, Pfefferbaum, and others that it recovers over abstinence, but it takes time. What's the situation in Germany, and I'm afraid in other European countries as well? We are allowed to treat them for 1 week, and then they should go out and cope and show that they are conscious persons with good self-control, and then we award them with getting into an abstinence rehab center, which is totally wrong, because after 1 week they look like that, and after a couple of more months, then, this is a 40-year-old woman without alcohol use disorder, they can recover. Now, we and others have looked for executive dysfunctions in patients, and this was never very strong. One way to look at it is, and that goes back to the computational modeling of reward learning, that's the so-called 2-step task. It's a bit complicated, but I'll try and guide you through with a simple example. Imagine you sit alone at home, you are detoxified, you stop drinking, you have no friends, you have lost your partner drinking, you can't go out in the pub anymore with your drinking buddies. But usually when you don't drink, you come to other options, like you could study for your exam, you can go to your self-help group. That's usually good, and drinking is usually bad. But there are some occasions you are terribly lonely, you feel horrible, you got a lot of bills, you have a bit consciousness, and drinking would be so much better than sitting there and feeling lonely and depressed. So a rational agent should repeat not drinking, or should stay not drinking, even if it would be good in this moment. A very rational agent that thinks about all the consequences. An agent, a person who just focuses on how do I immediately feel, would continue drinking even when it is a bad choice, because momentarily he or she feels better. And you can model the decisions like that and then see how do persons with alcohol use disorder, or more heavy one, alcohol dependence, and healthy controls function. And originally, we thought, well, people with alcohol use disorder, maybe because of some brain atrophy, they will make bad choices, they will look like this, and persons with healthy controls would look like the rational agent. And as so many hypotheses, it was wrong. We observed that the average model-based, model-free decision-making, the more rational one and the more reward-related one, was pretty much the same. But we had an interesting interaction with alcohol expectancies. If you tend to not think about the situation in a complex way, plus have high alcohol expectancies, and this is the group here, the relapses, then you have a higher risk to relapse. So it's not just being a habitual decision maker, but being a habitual decision maker plus thinking that alcohol could help you, that would bring you into a relapse situation. And the comparison to the patients who will remain abstinent is interesting because then they're quite well matched with respect to alcohol consumption previously. There's no big difference. Also income and all the social factors. Yeah? So it is a slight shift in how much you expect from alcohol plus what kind of decision maker you are. But it's not in general that we can say all persons with alcohol use disorder tend to follow a habit. It is really more complex, and it has also to do with what you expect from drinking. Okay, there's a second double criterion, that's the development of tolerance and withdrawal symptoms when you stop drinking. And I know that is a bit in trouble if that criterion is really good or not. I strongly believe we need it in addiction research, because without that, we only have the passion part, and there are so many passions that are not pathological. So if you can't talk about tolerance development and withdrawal, we lack an aspect of addiction research. This being said, there are many other occasions in which you get used to a drug that you take. I get used to my antihypertensive medication. If I were to stop it, I would get a kind of withdrawal symptom. That alone doesn't make an addiction. So looking at alcohol effects on GABA, key idea is alcohol has a GABAergic effect. It directly binds into a pocket of the GABA-A receptor, and then they downregulate under constant drinking. And during early abstinence, your GABAergic effect is gone, but your receptors take days, maybe weeks to recover. And that's an old study from colleagues of us in New York at Columbia University. Anissa Abidagam also study using nuclear medicine techniques to look at availabilities of GABA-A receptors. And the yellow parts you see are areas where after 3 weeks of detoxification, there's still a lack, a reduction in GABA-A receptors, and that may help to explain why patients could get a seizure. Or when the dysfunction is in some more autonomically relevant areas, you may have the sweating and the shivering. And likewise, alcohol interferes with the glutamate NMDA receptor, and they upregulate, and when you stop drinking, you have too many NMDA receptors that could contribute as well to having seizures or neurotoxic effects. And we know that we had a long discussion in the work of Rainer Spannagel, what acamprosate does if it really modifies the NMDA receptor function. It seems to be more complex, and it didn't do that well in some recent large-scale studies, but it's still one of the options to treat alcohol use disorder to reduce relapse rates. But, as I said, I have that with my antihypertensive medication. We also looked at antidepressive medication, SSRIs. They do not get you addicted. There's hardly a case where you see a patient taking an excessive dose of SSRIs in order to improve their mood. They don't work immediately. But when you stop them, you get some symptoms that are not just the reoccurrence of anxiety and depression, which is of course hard to distinguish from withdrawal, but you also get some symptoms like people feeling that they have an unpleasant electric feelings in their skulls, or some visual hallucinations or something like that, that look really like you have you miss the impact of the medication on your brain. Finally, to the reward part, that's probably simple. We know that alcohol, like other drugs of abuse, increases dopamine release, reinforces, I jump over the animal model, reinforces whatever you've done to release the dopamine, and it is also associated with a cue that predicts that the reward comes up. And the problems with drug of abuse are that they work much stronger than food or sex. For example, amphetamine releases about 10 times as much dopamine, impacts on the cues, and we have done a lot of studies looking at these cues in the brain, and we found that, you show somebody an alcohol picture compared to control pictures, you get increased brain activation in some areas, like the medial prefrontal cortex, that again also seem to play a role in animal models of excessive drinking. I want to come to one last aspect, and this is jumping here. This is, what do these cues do in real life? I mean, when people sit in a scanner, we know the brain activation can help to predict relapse, but what happens in real life? And I had one patient who said, when it gets dark, sky is gray, I walk alone through the streets, and I come by the bars, and I see this warm yellow light, and I hear the clinking of glasses, I'm lost. So the alcohol cues impact on a complex series of behavior patterns that are all goal-directed, they're all conscious. I go in, I say hello, I buy my beer. This is not just a habit running down, but it has a lot of impact with respect to what you think about what you do. And we try to mimic that by a paradigm that's called a Pavlovian to instrumental transfer paradigm, where you put alcohol cues in the back, and then they have to decide about collecting shells as a totally independent rational choice paradigm. And we thought when we put these alcohol cues in the back, they will just do a lot of mistakes. They will just collect whatever shell is around because they are disinhibited. But we saw the absolute opposite. We found activation in the ventral striatum, much stronger in alcohol use disorder patients. But the only patients who differed from healthy controls were those who would later remain abstinent. And what they did is when they saw these pictures, they stopped doing anything, which is probably a very smart strategy in real life. It wasn't good to collect shells. It didn't help them to be successful in the paradigm, but it probably helped them because the ones that didn't resume drinking probably helped them to use alcohol cues as a warning sign. And one final part I would like to address, that is that not only beyond dopamine, there are other neurotransmitter systems involved in alcohol reward. So if a reward comes completely as predicted, you tell somebody tomorrow I give you 100 euros at 12 o'clock sharp, or you give them the 100 euros, there's probably no more dopamine release because it's completely unsurprising, but you still enjoy it. What are the transmitter systems involved here? Also, if you eat your best loved food, you know exactly how it tastes. In the restaurant, you've been always going. And that's probably endorphins, and this also brings me back to a study we did in Mannheim. And these are mu-opiate receptors. We know that alcohol releases endorphins, yeah? And endorphins are also released when you hold a child. So some people may be predisposed to be very interested in this kind of result because they lack the feeling probably in their own development. And we found that there's a slight increase. I mean, it looks dramatic, but if you really look at the distribution, only a few subjects stick out that had a slight increase in opiate receptor availability. They had stronger alcohol craving, and probably they're the 1 out of 10 that respond to naltrexone medication. So again, here, these are all the impacts on learning from the rewarding aspects of drug intake. And one of the ways out, we try and support with medication, but mainly if that really impacts on learning mechanisms, patients need time. They need our patience, and they need sometimes several attempts to change behavior because it's not easy, and I'd like to compare it to making a wrong movement in sports. Yeah, it's very difficult to change that habit, and it takes time, and it takes space, and it also takes respect to the patients. And with that, I thank you for your attendance. Thank you.
Congratulations to Andreas, and that was a fantastic trip through the research that you've done over the years, so thank you for that. We have time for some questions now for Professor Heinz.
Congratulations. At the end of your talk, you did mention the endorphin receptor. And Sinclair, with his extinction model in rats, suggested we could unlearn. They would unlearn some, not all, aspects of the rewards from their drinking. So this is the paradoxical situation where you would tell your patients to go and drink, but you must take the naltrexone before, and you will gradually extinguish your liking for alcohol, at least on that dimension. What do you make of that?
Thank you very much. Very important topic. Well, what we believe is that in order to unlearn, if you look at the dopamine system, if you stop drinking and you encounter alcohol drugs, drug pictures, like you go through the street and you have all the advertisements, it should actually help you to unlearn, because there is a cue and then there's no reward, and then the situation is worse than expected. You should have a little dip in your dopamine. Now, if the whole system is down after detoxifying, this is probably one of the reasons why getting away is more difficult, because the whole system being downregulated, making a dip in an already downregulated system is problematic. We have tried with alcohol exposure, and we have been semi-successful. It was more strongly on self-efficacy than on craving, but we don't know how long to expose. Yeah, we put a glass there and we said we expose until you are not interested in it anymore. That's very subjective, and people may misjudge. And you may know that from the Dutch group of Reinoud Wiers, they do this pushing away of alcohol pictures, which is an idea to build up a habit of rejecting, because they found that there's a tendency to pull alcohol pictures towards you, and when you want to stop that, you take a bit more time. The first results were very strong. We didn't have an effect on drinking, but our group was probably too small. The effect isn't that strong as people hoped in the beginning, and it doesn't help with everybody, but some studies still showed that it helps in alcohol use disorder. So I think one is exposure and one is active rejection, and that both could help to reduce the tendencies, and the exposure without effect could also really be an extinction.
Thank you for this very nice talk. You were alluding to Schultz data on this learning mechanism that involves this striatocorticothalamic loop. You were more insisting on the role of the striatum. Are the other dimensions also involved in these learning processes?
Well, yes, the ventral striatum is like one of these densely innervated dopaminergic areas, and it always lightened up in our studies when we compared alcohol cues. But interestingly, you're totally right, we shouldn't neglect the other areas, because the brain activation that we found repeatedly to predict relapse was not the ventral striatum activation, but something in the medial prefrontal cortex, which probably is very close to the anterior cingulum, is probably just attention. So when people pay a lot of attention to alcohol cues in a scanner where there's no alcohol anywhere, and you're in a detoxification program. So it's highly unlikely that the picture over there should be anything else but a picture. And if you still show an attentive reaction in the brain, probably that is a key problem of bringing you into trouble, that it's difficult for you to disengage with the cues. Yeah? We had that in some persons, and some of our control persons who like to drink a lot, but we didn't really correlate it. But it would be interesting. I don't think it's specific to alcohol. It's just a question of how much you focus. But prefrontal areas interacting with the ventral striatum seem to be important. We never had a strong thalamic signal, I have to say, for whatever reasons.
Thank you.
Any other questions? Maybe we could bring back Robin. Robin Broom, did you want to? I very unfairly cut you off just as you're about to start, but
this has been a very interesting session. Just to Jürgen, that his map interested me because the US and Australia went in different directions from most of the rest of the rich world. And both of those are countries that have fairly autonomous states. And so there's a lot of work you've set for people to look and see what happened with the different policies that were undertaken in the different states in the US and in Australia, it seems to me. So I don't know whether you have thought about that at all, but it seems to me that you were setting us some real issues to look at.
Well, I mean, basically what we did is, since there is this APIS system, and AAA has a system where every little policy change is actually noted in all of the states, etc. So the idea was to get somebody interested in doing a PhD thesis on that. Unfortunately, we didn't find anybody, but that's still to be done one of those days. But very clearly, the 50 states, COVID was one of the times when there was a lot of alcohol policy going down. Most of it was dismantling existing control systems, but there were also some small changes, and somebody has to get through all of those data and do it, because we have monthly data in the US about consumption.
I had also one remark on Rem's talk. I mean, very nice talk. Which is, my remark is a clinical remark, as working as a psychiatrist. I mean, 3 of my patients, alcohol use disorder patients, died during that time. These were patients that were followed up, but who told me that being socially isolated, it was really unbearable. And I think that social isolation itself in these people that are fragile may be a sufficient reason for them not to be able to cope with their drinking problem. And so I think that this helps us see also how in our patients social contacts are really important to help them go on living, even though relapsing from time to time. This is very central to me, and this was a very important message that I remember from this COVID period.
I cannot agree more. I mean, basically what happens is from the very beginning, we said stress will do all of this without looking at the real mechanisms and without trying to disentangle what actually happened, or without trying to actually operationalize stress correctly in a more controlled setting as much as it's possible. So I see still a lot of research being done on the single mechanisms which are there, what happens to people who drink a lot and who increase their drinking to adapt to whatever new state, and what are the real triggers, and how far, and what is the explained variance of those different mechanisms. I think we are making shortcuts by calling it all stress, and that doesn't help for the long run, because we need to understand better what are those mechanisms and what can help in the future for those people who are affected.
Okay, I don't see any more hands up or questions coming, so I think what we should do is to end the session, first of all, by thanking our two fantastic speakers. Thank you to you, the audience, for some really good questions. Thank you to Karen, my co-chair. And also thank you to Inej from Karger, who's supported this award today. So thanks for joining us, and hope to see you next time. Thank you.